Now, the question is, what is the most common cause of heart failure? It depends on the age. In a premature baby, it's a volume overload, whether by fluid or by PDA. That's the most common cause. The other causes are anemia and the other causes in premature babies is sepsis. In term baby, it's asphyxia and congenital heart disease. When you get older, you get the myocarditis and arrhythmia. Of course, in preterm baby, rarely you get also arrhythmia like SVT. However, when you get older, not the SVT become the problem, but because when you get older, the SVT will take about 3 days to cause heart failure and usually treated. When you get older, you get another type of trauma in addition to myocarditis. When you get a little bit older, cardiomyopathy added to the board, and myocarditis start to be there. And you know, the causes are expanded. Congenital heart disease is rarely cause failure in neonatal period, usually start about 2 months of age. So that's my answer would be about causes, the most common cause of heart failure, depending on the age. Which inotrope you start? I will start with diuretics. I will start with Lasix. I usually give testos. And then if improvement, I start the boluses. I might need to go to infusion and they check the electrolyte and the gas. If no improvement, I add to it inotropes. And the most common inotropes, I start with dopamine. I reach 10 and then I add dobutamine. And if I control the blood pressure, I add milrinone, especially if I have hypotension. If it's more severe, I go with norepinephrine and epinephrine. If I have renal problem, then I would go with vasopressin. Really depend on if it's stage 2 and C, I start with angiotensin converting. I will start with enalapril. If no improvement, I add the beta blockers. If stage C and I've started angiotensin converting enzyme and beta blocker, I might add digoxin. I do not advise digitalization. It's useless. Okay, that would be my answer to medication or inotropes. Any more questions? Questions?
Can I ask you, Dr. Yahya?
Go ahead, please.
Yes, in case of carditis, sometimes you say that it is a good prognosis, maybe in your place, but
No, I didn't say a good prognosis. I meant compared to other causes.
Yes, yes, but here sometimes we face such cases. Most of them may go into death, really.
Yes, but what is the cause of the death?
Yes, but most of us, we are using Lasix and supportive, of course, oxygen like that. And sometimes we may use ventilator if there is no response. Is there any, my question here, is there any rule for immunoglobulin or steroid in case of viral carditis in young infants?
No steroid. Immunotherapy only in some type of cardiomyopathy. There are certain type of cardiomyopathy, especially in neonate, and those especially with mother connective tissue disease. So if you have a connective tissue disease in that patient and you have a heart failure, then you might have a rule. Even with that, the rule is not great, but you might have rule immunotherapy. Steroid is the answer is no. Steroid have no rule. The most common cause of death is inability to use of the non-pharmacological tools like non-invasive ventilation and ventilation.
Yes.
And also there is no rules for antibiotics. Yeah, so I think the problem and the death is because of improper ventilation, because we need a real session on how to ventilate. Well, you need to know how to ventilate in general, but you need to know how to ventilate a heart patient. because remember, heart is failing, and also the heart is a big size. And when you ventilate the lung. So the lung will interact with the heart, with the ventilator, and with the output. So you need to know how to ventilate, how to give PEEP, how to give PIP, how to give the rate, how you give inspiratory time, how you give expiratory time, how you give the rate, how you monitor the heart, how you monitor the preload, and how you outerload. It's very critical to monitor. And you need to use your medications in accordance with the renal, with respiratory problem. So I think the reason of the death is availability of PICU care, not because of the heart failure.
Yes. Okay, thank you very much, Doctor. Thank you.
Any more questions?
So Yahya, can I ask a question, please?
Go ahead, please.
Yeah, I have 3 questions. The first one, if I cannot detect the blood pressure, I cannot check the blood pressure in small infant, what is the sign of decompensation which can I depend on?
Why you cannot measure the blood pressure in? I can measure a blood pressure in a 24-weeker. Why you cannot?
Because we have no small cuffs for neonates.
Okay. But remember, small cuff are available on Amazon, so you can order online, and they are $25 per cuff. If you don't know, I can show you. It's $25 per cuff, and you have from 24 until adolescent. So you have all the sizes. And yes, with the new monitors, when you put your cuff, you can time your monitor, okay, and the monitor will measure your blood pressure, give you systole, diastole, and systole. Because remember, the new monitors does not depend on the Korsakoff sounds. They depend on oscillation because they use the pulse transit time. And therefore, they can give you systole, diastole, and mean. And you can time the monitor to give you the blood pressure every 5 minutes or 10 minutes or every 5. So it's an invasive measurement. And the cuffs are available online on Amazon, and they are as cheap as $25. So when you don't have blood pressure measurement, you are in a real trouble. However, you have to depend on other features of perfusion, which is the capillary refill, the urine output, the lactate. So if you can measure the lactate, and most of the lactate are measured by blood gas, and the best if you have like unstable patient, even the peripheral is not good. So you should have arterial line with an adapter to measure the invasive blood pressure. And if you have a central line, like a line or a jugular line or a femoral line, and give you the central pressure, that will be great. Because when you have an arterial pressure and you have a central pressure, you can measure the cerebral blood flow. So I think all goes to the same line, is absence of PICU care, pediatric intensive care. That's the whole problem. And I can tell you, most of the patients, in my experience, die in non-acute situation. So we decide to let them go. So I never had a patient who died because of myocarditis and he's decompensated, because I can control it easy. Lasix, inotropes, ventilation, I can keep the patient alive for months. But proper ventilation, that's I think the whole idea. And you're really in a tough spot if you don't have blood pressure.
And if I decide, if I decide it is a decompensating heart failure, I will start with dopamine and dovitamin.
No, lasix, diuretics. You start with diuretics.
But this is hypotensive patient. The patient has hypotension. If I give
hypotensive patient, so what you need to do is to give dopamine
and dovitamin.
10 mic, and yes, that will cause you some vasoconstriction. Because remember, with dopamine, I would start with 2.5 or 2, and then I increase it to 5 or 6, 8 until I reach 10. When I reach 10 and still I have hypotension, that it depends hypotension which one is. Like if it's a systolic, then the dopamine is good. If it's a diastolic, then you need dobutamine. So usually I start with dopamine, I reach 10, and then add dobutamine as infusion. And by then I would be able to decrease the preload by giving Lasix. I never faced a hypotension problem when I use the target charge of blood pressure according to the gestation and age and monitor the blood pressure. I usually do not face, but if you face that, then you decide, is it systolic problem mainly, or it's a diastolic problem mainly? Because it is, if it's a systolic problem, you will see the distance between the mean and the systole is shorter than the mean between mean and the diastole. If it's a diastolic problem, you have low diastolic, and the distance between diastole and mean is shorter than the distance between mean and systole. So you choose dopamine or dobutamine. If you still have a problem with that, then you end up with norepinephrine. That's would be your best choice. Because epinephrine, if you use epinephrine, it's more load on the heart. So I would use norepinephrine. If all, go ahead.
Yes, my second question is there is a rule for carnitine in dilated cardiomyopathy in a unit?
Carnitine is mainly for metabolic problem, but if you don't have metabolic cardiomyopathy, then it's no. So carnitine is a nutritional only. We use carnitine in neonate as a maintenance. So if that's your question, we give carnitine all babies. So we give 50 mic per day as a dose.
Yeah.
With the TPN, we give it. But when we stop the TPN, we don't give it. So we give the carnitine as a maintenance. But as a therapeutic, you have to reach up 100 and 150 and 200. It's only when there is metabolic problem. Now, maybe your question, you have a cardiomyopathy, but you don't know the cause.
Yes, I have no genetic study.
Yeah, so you don't need sometimes the genetic study to reach the cause, but sometimes you cannot reach the cause. I think that's your question. I don't know the benefit in acute situation, because all the acute situation is a pre and so you have a pre, you have afterload, and you have contractility problem. I don't know carnitine will help. Carnitine will help in the growth. Carnitine will help in improving quality of life. Carnitine will help in decreasing probably mortality. I don't have evidence, but I'm just assuming. But in acute situation, unless it's acute metabolic decompensation, I don't think you'll have a role in that.
So my last question is about the heart failure due to arrhythmia during neonatal period.
Okay.
If I have a unit with SVT and I try to give first dose of adenosine, second dose, and third dose, and there is no benefit, can I use cardioversion? Can I use cardioversion to
First, you are mixing up between SVT and heart failure. SVT usually does not cause heart failure until you have a high rate, more than 180 for at least 72 hours. It's very unlikely that SVT cause heart failure within a few hours. That's one. Second, when you treat SVT, you should treat it before you go to heart failure. So vagal stimulation is rarely effective. So I do not advise pressure on the eye or ear stimulation. I would advise only ice on the forehead, and I give it for 10 seconds. I don't continue, and then I remove it, then I put it again, because the whole issue is to cerebralize the patient and decrease the heart rate. If you don't have response, I would give adenosine. And I give adenosine. It's better to be in a central, not a peripheral. If you don't have central, then you have to give very good flush. So if it's a central, I would give 1 ml of normal saline. But if it's a peripheral, I would give 10 ml of normal saline when I flush it, because I need it to reach to the heart. If I don't give 100 nanogram I give to 200, or I give 250, microgram, sorry. If no response, then I go for cardioversion. Okay? And I would start with 2 joules per kg. I would start with 2 joules
even
per kg.
during neonatal neutral
Yes.
period?
Yes,
Even
I used it in a 24-weeker. Cardio, I used it myself. I used it for a 24-weeker. There is no problem with that, but you should have the gel, and also you should have the children pads. So they are equally slide with the adult pad. I don't think it's appropriate to use the automated cardio version, the external fibrillator. But it's okay to use the cardio version. Yes, synchronized cardio version. We used it in neonate many times because you reach to a point you might have a heart failure. But when I will use it, I give adenosine and is not responding, and I continue monitor the patient. When I start to see a sign of decompensation, yes, I start cardio version. But again, it's very rare. Like in my career, 17 years of neonatology, maybe I did it twice or 3 times. Like it's rarely needed. Adenosine usually function, and also you can use beta blockers. So especially the esmolol, because it's very short acting and it's very rapid, and you can titrate it up and down. It's better than carvedilol or misoprolol. It's very good drug, and I rarely see SVT is not treated by that. Okay.
Thank you, sir.
You are most welcome. Thank you for
thank
asking. Any questions? Any more questions? Well, thank you everybody for attending, and have a good night. Okay, I will post in 2 file, one the presentation and one for the questions, because it will be too long for one video. Okay, thank you very much. Thank you very much. And do you have a question?
Thank you very much, Doctor. Thank you.
Thank you very much. Thank you very much. Take care. Bye-bye.
Hard work, really.
Thank you very much. Take care.